Afternoon. Thank you for having me. I know most of you, but for those that I don't, my name is Tom York. I'm one of the lead research physicians here at Richmond Pharmacology. As Dr. Taubel said earlier, this is a hastily relabeled set of slides. I'm stepping in for Dr. Don Pimenta, who sends his apologies but is off today with COVID, so unfortunately can't be with us. This work is very much the product of Prof. Moore's, of Dr. Taubel's hard effort, so hopefully I can do it some justice in presenting it today. First of all, a little bit about where this work is coming from and the section of our work here at Richmond. So this is being done under the auspices of Richmond Research Institute, which is our non-for-profit academic research organisation, which works across really multiple different fields of clinical research, ranging from sort of basic life sciences, looking at QTc risk in hyperglycemia, through to digital health with some work in telemonitoring on ATTR cardiomyopathy that you might be familiar with, and all the way up to big data analysis and some machine learning with ECG studies we're doing. But today we're looking, obviously, at a study involving the liver, which by our internal code is 1930, that some of you may have heard of. So, looking at non-alcoholic fatty liver disease, it's already been emphasised over the course of today, but obviously it is a clinical spectrum of disease, ranging from really benign infiltration of the liver with fat to inflammation, also termed steatohepatitis, which can progress through to scarring of the liver as cirrhosis. That then to liver cancer, failure, and potentially death. I think has already been mentioned, NAFLD is a really common condition and affects 1 in 4 of the global adult population. Now, clinical risk factors for it are mostly metabolic things, so obesity, metabolic syndrome, insulin resistance, type 2 diabetes. Although the phenotype there is relatively simple, the underlying pathophysiology is anything but simple. And you can see from the diagram on the right-hand side there from a recent paper in Biomedicines, this really just details all the various targets for treatment for NAFLD. As you can see, this covers a really wide range of biological processes. So there's glucose metabolism in there, metabolic regulation, lipogenesis, bile acid metabolism, and fibrogenesis as well. Some of those areas are showing real promise. For example, the PPAR agonists and the SGLT inhibitors that you may be familiar with as well. Now, why are we interested in this? Well, we're interested in NAFLD in clinical trials due to the potential for fatty liver disease, particularly NASH, that non-alcoholic steatohepatitis, the sort of next step on to influence drug metabolism. Now, the table you can see here is adapted from Merrill et al., and it correlates various clinical studies in humans with NAFLD on both phase 1 and phase 2 drug metabolism. Now, human studies tend to be performed in opportunistic cohorts. So we're thinking examples such as somebody going in for bariatric surgery and having a biopsy at the same time. And that inevitably leads to a degree of bias, obviously. However, it's clear from this that at least sort of on the lab bench, enzyme activity is deranged up or down by NAFLD. Now, whether that translates into something which is clinically significant at the bedside, I think is a clinical question that's sort of yet to be answered. Another really important consideration when examining new medications, of course, is that there is some evidence that suggests drug-drug interactions may also be enhanced by NAFLD. You can see a paper on the right there for that. Now, those two things are pretty clear reasons as to why we want to identify NAFLD in clinical trial participants, and I think Prof. Moore's explained that as well earlier. To support the potential impact of this problem, this paper, which I think again has been earlier referenced, Takyar et al., looks at 3,200 apparently healthy volunteers across 149 studies from 2011 through to 2015. Headline figures from that, notably 55% were overweight with a BMI of greater than 25, and 44% had an abnormal ALT at screening. Perhaps the most important part of it, though, of 5 grade 3 or 4 liver reactions that were seen on these trials, 4 of them occurred in volunteers with probable fatty liver disease. So that represents a 4 times increased risk from the baseline. Identifying NAFLD, therefore, will improve our precision in eligibility, in theory, make clinical trials safer by possibly reducing liver-drug interactions, and improve trial efficiency by removing some of those compounding unknowns, specifically NAFLD and NASH. So here we are coming to 1930 then. We are recruiting 1,500 volunteers from 2 pools, healthy volunteers and patients, the latter cohort being screened opportunistically as patients with hypertension, diabetes and known fatty liver disease come through our unit. Once here, they undergo a full battery of biomarker assessments, including bioimpedance, blood biomarkers such as insulin, CRP and glucose, and anthropometric measurements, so things like waist circumference as well. It's been mentioned earlier, similarly, but Fibroscan is then performed as our proxy gold standard to classify NAFLD either being present or absent, and then the severity of it if it is present. Beyond that, we apply 2 forms of data analysis, so traditional either logistic or linear regression modelling, and slightly more excitingly, machine learning techniques, which we'll touch on later. The end result of this, the hope of what we're trying to get to, is a clinical prediction tool that a research physician can have in their hands in the clinic. Whether this will be a sort of simple scoring system or a cloud-based algorithm that you can access through an app on your phone remains to be kind of decided. But the end result we're aiming for is that you have a practical, implementable tool that can help screen out NAFLD in trial volunteers in a way that's cost-effective and safe. So just to circle back briefly then to the Fibroscan, we've mentioned it's being used as our gold standard. At the top of the image there, you can see a Fibroscan, which is really just a specialist ultrasound probe that assesses 2 parameters. So the CAP, which is the controlled attenuation parameter, and the E-score, which is for elasticity. Those 2 reflect liver fat, steatosis, and fibrosis, respectively. The Fibroscan expresses these as numbers that you can see in the tables, CAP in decibels per meter and an E-score in kilopascals. We use those to classify severity into a score of S1 to 3 and F0 to 4. Clinically significant disease is broadly considered to be above S2 or F2. Fibroscan correlates well, but not perfectly, with liver biopsy for steatosis and fibrosis, with an area under the curve of between sort of 0.7 to just under 0.9. So there's a high degree of correlation, and in this kind of context, obviously it's a much more acceptable means than an invasive liver biopsy to test for this. Moving on then to a sort of snippet of the results we have so far. So from the latest data analysis of 259 individuals, to orient, we have the E-score for fibrosis on the left and the CAP score for steatosis on the right. Now, these are initial results for the logistic regression, detecting whether there's significant disease or not. These are 20 variables which were chosen for sort of biological plausibility. You can see on the left side that many of these factors are highly significant as predictors for NAFLD, and those include age, BMI, waist circumference, body fat percentage, and HbA1c, liver enzymes, and diabetes as well. For steatosis, white cell count is also a significant factor, which is probably part of that inflammatory syndrome of obesity that we see as well. Now, using 2 factors, those 2 you can see highlighted in sort of pinky colour, as the sort of first step to creating a classifier tool, we create these values, the AUC values that you can see at the bottom. And the value for steatosis is 0.807, and the value for fibrosis is 0.807. The value for steatosis is 0.877. Now, to give you a sort of impression of that, a perfect predictor, something that was predicting with accuracy 100% of the time, would score 1. To put it into context for something which we might use in kind of more common clinical practice, Many of us will have used or heard of the Wells score previously. That achieves an area under the curve score of around 0.55. So we're substantially beating that already. It's little better than a sort of flip of the coin. Obviously, with sort of further data, as we collect more data, we'll be able to refine this and progress these variable analyses into a score which is becoming even more clinically useful. Lastly, if we look a bit at the future of where we're hoping to progress with 1930. So, machine learning analysis. We're working with Prof. Moore's group at UCL to see if a new form of computational analysis, which has been mentioned already, paranclitic networks, is a way to better yield a classifier for our data set. Paranclitic networks are really a way to look at complex, sort of highly dimensional data and work well in biological systems such as cancer and genetics. On the slide here is a paper from Prof. Moore using a similar biomarker data set to predict survival and prognosis in liver cirrhosis. We hope to do the same here with these paranclitic networks. Once we have sufficient numbers, we will also conduct subgroup analysis, specifically in the healthy volunteer group and the patient group. And as looking harder at these groups is something that might allow us to develop sort of cohort-specific tools that will be even more clinically useful. Over the next year, we plan to keep recruiting, so a target of 500 by Q3 of 2022, and 1,500, so the total sample size, by Q3 of 2023, with a publication of an app and subsequent scientific publication in the following 6 months after that. It's a brief summary. That's it for this one, but thank you very much. Any questions? Happy to try and answer them between us, I think.